Thank you so much to Associate Professor Whelan for that very intriguing talk on the management and treatment of ATTR amyloidosis. Next, we will welcome Professor Kastritis to talk about AL amyloidosis.
Thank you so much. Grateful to be here with you in Sydney this very nice Saturday morning. Thank you for inviting me to Australia to talk with you about my experience in treating patients with AL amyloidosis, the type of amyloidosis that is produced by light chains that are coming from these bad clonal cells, the plasma cells, the clonal plasma cells that exist in the bone marrow. So, as you know, the major problem with this disease, it's too complicated. And as a result of being so complicated, it's the late diagnosis, and this is actually our biggest problem. Most of the patients that we see in our practice, everywhere in the world, have been diagnosed most of the times at late stages, which means that they have many different organs that have been affected by the amyloid. The heart, that you heard about, what happens and how complicated it is to manage, but also the kidneys, the liver, the stomach, the intestines, the tongue, the skin, many more organs. So this is one level of complexity. The other level of complexity is that this disease, AL amyloidosis, can affect also young people and also older ones. So you have a very big spectrum of different patients that you have to treat with the treatments. And of course, one has to be very accurate with the diagnosis because, as Dr. Whelan showed, different types of amyloidosis may actually show with very similar clinical presentations. They both ATTR and AL affect the heart and the peripheral nerves, but they have totally different treatments. So most of the patients with AL amyloidosis will have many of these symptoms, may have 1, 2, 3 different of these symptoms, may have some abnormal tests in the blood or in the urine, may visit many different physicians. Actually, most of the patients, they will need to visit maybe 3 or 5 different physicians before we reach at the end at the diagnosis. So one has to suspect the disease in order to make the correct diagnosis, and this is actually one of the most difficult parts in the management of this disease. Fortunately, more than 99% of the patients with AL amyloidosis will have at least one abnormal biomarker: free light chains, anti-proBNP, troponins, alkaline phosphatase, proteinuria. But the main issue is that one has to do all these tests in order to have this 99%. So this is very important to suspect the disease. And after you suspect the disease, the next step for AL amyloidosis is a biopsy. You need to confirm that there actually is amyloid there, and that amyloid exists. And there are many different organs in which you can do biopsy. You can go directly to the organ that you think is mostly affected, the kidney, the heart, the liver, which is sometimes tricky. Or you can go and do fat aspirate. It's very easy. I do it every day in my practice. You can get fat aspirate, and maybe in 70 to 80% of the cases, you can find the amyloid there, and you can make the diagnosis. Or you can ask your dentist to get a biopsy from the gum or the salivary gland. So you avoid, most of the time, to get a biopsy from an organ such as the heart, the liver, or the kidney. But sometimes, inevitably, you will have to go to the kidney or the liver of the heart. And after you get the amyloid, then you have to do the typing, because all amyloid fibrils, independent of whether they come from light chains or from transthyretin, They have the same color in the microscope, and it's very difficult to, you cannot differentiate. You have to do what we call typing, which is a more complicated process. So that is why, in order to treat patients with L amyloidosis, you have to have a multidisciplinary team. You have to have many physicians, many doctors who have a close collaboration and can really fast exchange information about the patient we have in front of us. That's why it's very important to have an amyloidosis center, like the one in London, the one in Sydney. You have several of them in Australia. And as you can see, many different physicians will link to run together. We try to do this everything in one day in our amyloidosis center in order to get the diagnosis and many more physicians to care for the patient. The renal specialist, the neurologist, of course, cardiologist, the hematologist who is going to treat the disease. Because in AL amyloidosis, what are the goals of treatment? You will hear, maybe from your physicians, your treating physicians, that we have hematologic response and organ response, renal, cardiac, whatever. And actually, yes, in AL amyloidosis, we have two levels of response. The one that we call hematologic, which is the treatment that we give to reduce the production of the light chains that produce the amyloid fibrils. And if you reduce these light chains, then you will get what we call an organ response, which is the improvement in the function of the heart, of the kidneys, of the liver, etc. So, how do we follow this hematologic response? Well, we measure the free light chains, you probably know this, and we also do another test called immunofixation to check for very, very small amounts of monoclonal immunoglobulin. And our goal is to reduce the free light chains to become normal or almost normal. Our aim is to reduce them to almost normal. Of course, in sometimes small amounts may still be there and may affect organ function, or the amount may still be there, but the organ function may improve because the toxicity of these light chains is different in every patient. What we know, however, is that if you reduce, the more you reduce the light chains, the probability of improving the heart function increases substantially. So this is our goal today, to reduce, to eliminate the free light chains. What is also very important to remember is that we have to go to this reduction of the free light chains to eliminate the free light chains very fast. And we have actually done a study showing that even if you delay 2 months to achieve your goal of eliminating the light chains, this may be very detrimental for organ function and even survival. So you have to eliminate, and you have to do this very, very fast, probably within 1 or 2 months from starting treatment, because actually we are here. There's a hole in our boat in the middle of the ocean. The water comes in. We have to stop the light chains from producing amyloid. And then our cells, we have cells, macrophages, will slowly empty the boat and will improve the organ function. But how do we follow this organ function? Dr. Whelan showed you how you follow the heart. We have different biomarkers for each organ. We follow, for example, NT-proBNP, which is a biomarker of cardiac stress, troponin, which is a biomarker of dying cardiac cells. We also have imaging studies such as echocardiography and cardiac MRI. For the kidneys, we follow blood creatinine, the protein in the urine, mostly the albumin, and the albumin in the blood. For the liver, we follow the alkaline phosphatase, we follow the size of the liver, and also the size in echo or with MRI. So how do we get there? To reduce the light chains and improve the organ function, we need to have treatments that kill the plasma cells that produce the light chains, and we also know that these treatments have to be not very toxic, because most of the patients with AL amyloidosis already have enough problems with their hearts, kidneys, and peripheral nerves. We don't need to add more toxicity to these organs. These are the treatments that we use and the efficacy. We mostly now use and I know that is available here in Australia, the combination of daratumumab with cyclophosphamide and dexamethasone. These are 4 different drugs. Daratumumab is a monoclonal antibody, like the antibodies that our body produces to fight, for example, influenza or after vaccination, but it's produced in the lab and identifies a target on the surface of the plasma cells and kills the plasma cells. Bortezomib is an old drug, about 20 years old now. Cyclophosphamide is a very, very old chemotherapy, but very mild chemotherapy that helps improve the efficacy. And dexamethasone, dexamethasone is a steroid. But each drug has its unique toxicities, and we must be careful on how to use it in terms of dosing and scheduling. However, before I start treatment for any patient, first I check whether also this patient may be eligible for a clinical trial, which would give my patient the opportunity to receive a new treatment that could further improve the outcome. And I know I have so many patients that were enrolled to the clinical trials who received, for example, daratumumab several years before this become available for everyday clinical practice. And many of them, actually, their lives were saved because they participated in clinical trials. So, in this study that already mentioned, the Andromeda study with a combination of daratumumab with the other drugs, more than about 60% of the patients achieved complete elimination of the production of the light chains. This is fantastic. That was 3 times higher than with the standard regimen. And that was also really fast, within 2 to 3 months. About 45% of the patients improved the function of the hearts. This is very important. And also, about 40% improved the function of the hearts so much that their biomarkers, the NT-proBNP, the stress biomarker, became normal. So this was a huge improvement. That was 3 times higher than with the standard therapies. So certainly, we can improve the outcomes with this treatment, but still we need to do more because there are still patients who do not achieve this depth of response. Also, the final analysis that we presented a few months ago showed that by adding daratumumab to VCD with these 4 drugs, we actually substantially improved the overall outcome, which means the survival of the patient with amyloidosis. I think many patients with this disease were saved because they received this treatment. So, these drugs are used subcutaneously, daratumumab. You may need to receive some additional drugs to avoid overreaction of the immune system during the first 2 or 3 injections. But generally, it's very well tolerated. You initially receive this drug every week for 9 weeks, then every 2 weeks for 4 months, and every month for another 1.5 years. Bortezomib is also used as a subcutaneous injection, but may cause fatigue or may cause peripheral neuropathy. You need to be somewhat careful with this drug. Cyclophosphamide may cause nausea, can be given either intravenous or by mouth, pills. The problem with the pills is that you need 10 pills to get the dose. However, they are very small pills, and you save the time of being on the chair to get an IV injection. So most of my patients, they love the pills because they don't have to wait. This takes 5 minutes, 3 seconds, no time, so they can come in the clinic and leave within 15 minutes. And steroids, of course, dexamethasone may cause a lot of different problems. So some patients will have in very advanced stage of cardiac amyloidosis. For these patients, we certainly need to have a very close collaboration with our cardiologists. We call these patients stage 3B. It's because they have very, very high levels of NT-proBNP and very high levels of troponin. And for these patients, we have to be very careful because their hearts are very weak. So what we're trying to do is adjust the doses of bortezomib or dexamethasone. We give them daratumumab because it's very effective and very safe for the heart. And I think we have substantially improved also the outcome of these patients. We are very far from being very good, but we have really done a good work. So, what are the realistic expectations for the treatment of patients with AL amyloidosis? First of all, one has to remember that this is a disease that was there for several years. We know that the light chains were there for at least 10 years before we identified amyloidosis. And it will take a long time until the organs improve. First, it will come the hematologic response, the light chains will go down, and then slowly we will see the improvement in the biomarkers of the heart, of the kidneys, of the liver. So one has to be patient and has to have realistic goals for the progress of the disease. It is not very easy to follow the biomarkers. If you try to follow yourself the biomarkers, it may be very complicated. It's also complicated for us because many of these biomarkers are affected by many different things. You have to keep a diary for your health. It's very important when you communicate with your physicians. You have to maintain some exercise. This is very important, especially because many patients receive steroids. A healthy diet is important. And you have to be very careful about infections. Daratumumab is reducing the immune response. Velcade, the same. Cyclophosphamide, the same. Steroids, the same. So you have to keep track of your vaccination status. Okay, and you have to wait. Then the response needs time. So sometimes, unfortunately, the treatment that we start with may not be so successful, so we may need to change treatment. Again, there may be a clinical trial with a new and very, very effective treatment. Like when there was no daratumumab and suddenly daratumumab came and patients who had not been exposed to daratumumab received daratumumab, they had fantastic responses. So if someone has not received daratumumab, this is an excellent choice. Very, very effective either alone or in combination. You can see here the results. Another very, very important drug is are the drugs that target BCL2. Okay, that's too complicated, but these are pills that are very effective in patients in whose the plasma cells, the cells that produce the light chains, have this translocation, T1114, and they are very, very sensitive to this drug. And you can see very, very high response rates very, very rapidly, but only in these patients. And the other patients are not effective. How many are these patients? About 50% of patients with L amyloidosis. So it's a very good option. Now, a very good option that is coming and will be available at least in clinical trials, it's also available in patients with myeloma, is the drugs that target antigen, a protein that is in the surface of the plasma cells, which is called BCMA. And these drugs are very, very effective. We have belantamab mafodotin, which is a monoclonal antibody which has a toxin bind to it, so it kills the cells by inserting the toxin in the cells. And the bispecific antibodies, you may have heard of these bispecific antibodies, which actually bind a T cell to a plasma cell. So they take the killer cell of the immune system, the T cell, and they put it next to a bad plasma cell. And also they make it very angry. So the T cell kills the plasma cell, and they are very, very effective. And there are other drugs that are also important and may be used in combination with the previous drugs, such as lenalidomide and pomalidomide, which need to be adjusted in dosing in patients with AL amyloidosis. And what about transplantation? Well, this is a very good treatment, but it is a very toxic treatment, and one has to be careful when transplanting patients with AL amyloidosis. You need to be careful because of the toxicities, and could be a good option for very selected, carefully selected patients. And finally, there is another type of amyloidosis called IgM amyloidosis, in which the clone is not exactly the plasma cell, but is a cell called lymphocyte, which is not as mature as the plasma cell and has slightly different physiology and different targets. So many of the drugs that we use for the AL amyloidosis are not as effective. So for these patients, we have other immunotherapies, other chemoimmunotherapy combinations, and we have also new drugs coming. and we expect to improve further. And with that, I would like to thank you very much. This is the name of my colleagues in Athens in Greek letters. Thank you for your attention and for your patience. Thank you.